Good morning, good afternoon, everyone. Welcome to today's DCB Academy lesson on the wire and catheter selection for various type of lesions, which will be presented by Dr. Leo from Romania. Please, Dr. Leo, the podium is yours.
Hi, everybody. I'm going to try not to be very boring because this is a basic lesson, but maybe for those who are not so into interventional cardiology or didn't work for so many years, this might be useful. So wires and catheter selection is very important for the success of a good and safe intervention. Just a moment. Regarding the guide wires, there are three main components that are of great interest. First, the central core, which is the inner portion of the guide wire forming the backbone. In this case, there are three main principles that must be taken into consideration. First of all, the core diameter, which is not so important because most of the wires are 0.014. But there are two other specifications of the guide wires which we should talk about. First, the core material, which can be stainless steel, which provide good support and good force and torque transmission, but has the disadvantage of kinking and less flexible. Now, many guide wires use nitinol, which was introduced with the BMW guide wires in the 90s. Is more durable and it's trackable and flexible, but has a reduced torqueability and has the likelihood of wiping. So it must be torqued very slowly. Secondly, regarding the core tapering, it can be done in two different ways. With shorter taper, which is more rigid and torqueable, this is mainly used for calcific lesions and provides greater support and transmission of push force. But the ones who have a longer taper are more flexible and capable of negotiating bends and tortuous vessels. Secondly, the second important part of the guide wire is the distal tip. The distal tip has basically three important designs. One-piece core or core-to-tip design, where the backbone of the guide wire goes until the tip. This is the core-to-tip design. It provides support to entire guide wire from proximal to distal end, and it may be tapered at the end, providing good support for calcific lesions. The two-piece core or shaping ribbon design, which can be used in wires that are used for not so calcific lesions and in tortuous vessels, or the hybrid distal tip, which can be Act 1 technology introduced by Asahi guide wires, for example, in SOC 3 guide wires, or inner coil. The tip can be covered with coils or polymer or plastic jackets. If every guide wire has some advantages and disadvantages. For example, the polymer jackets can easily negotiate calcific lesions, but they are more likely, because of the less good tactile sense, to go under the plug. While the coil tips, which are mostly used in more than 90% of the guide wires, they give flexibility, and in the distal portion they have a radio-opaque platinum coil. Last but not least, the surface coating is very important for the guide wire, and we have to know each wire how it is designed regarding the surface coating. There are two major types of surface coating: hydrophobic or hydrophilic. Both of them reduce the thrombus formation, but the hydrophilic one is known to reduce it more. And the hydrophilic coating guide wires must be wet before introducing them into the catheter. So Taking all this into consideration, we can classify the guide wires in three major categories. The workhorse guide wires, which are suitable for the majority of cases and lesions. These wires have a flexible tip, or should have a flexible tip, that can be easily shaped. With easy maneuverability into the desired position, they are able to track through a tortuous and angulated lesion. They should also have a good torque transmission to the distal tip for more precise steering. They have a good tactile response, besides support and lubricity for smooth device passage. Such wires are, for example, BMV, Cyan Blue, or Antru Floppy. The extra support guide wires, they have an additional rail support for device delivery in challenging cases such as tortuous or calcific vessels. They must have a soft tip for a stiffer shaft and a shorter core tapering. The disadvantages of these wires might be the pseudocenosis that can be formed in tortuous vessels, and they also have a greater prolapse tendency. Some examples of these wires are the Cyan Blue extra support, the Grand Slam, the Whisper extra support, or the Choice extra support. And the third major category is the wires used for tightly senosed or CTOs lesions. In these wires, the core is usually made of stainless steel or high tensile strength stainless steel with larger core diameter and shorter tapering. The tip may be tapered for increased penetration force, and they might have a hydrophilic or hydrophobic coating. Some examples include Fielder family, Gaia family, Confianza, PT2, or Choice PT. However, in CTOs, we usually, or in most of the cases, change the wires from case to case from every step of the CTO procedure. For example, for negotiating the proximal cap, when we have a visible microchannel, we usually take a low penetration force wire with polymer jacket that can go into the microchannel, and then if we are unsuccessful, we can go with the intermediate penetration force wire. We escalate the wires from time to time. When we have a taper proximal cap, we get a low penetration force wire, and in case of unsuccess, we escalate to an intermediate penetration force or high penetration force wire. And in case of a blunt proximal cap, we go straight to an intermediate or high penetration force wire. After we penetrate the proximal cap, if we have a short length lesion, less than 2 centimeters, it's reasonable to go on with the same wire that we use for the proximal cap. But in case that in the cases we have longer lesions, we have to step down to a low penetration force wire. Then when we get to the distal cap, we can also escalate to a higher penetration force wire if required. However, there are three main strategies for penetrating a CTO. First one is the controlled drilling strategy. Usually we start with a guide wire with moderate tip stiffness, having good torqueability and tactile response. Such wires are the wires from the Asahi Miracle series, or the Persuader from Medtronic, or Hyper Progress from Abbott. They are without a polymer cover at the distal wire, or they have a hydrophilic or hydrophobic coating. However, for a controlled drilling strategy, sometimes we need progressively stiffer wires. The second strategy is the penetration strategy, in which we start with stiffer guide wires, but with wire tip shape and curve similar to the drilling technique. More aggressive directed forward probing with minimal rotational tip motion is required to be able to penetrate such lesions. Some examples of such wires that can help us in these lesions are the Asahi Conquest Pro, the Conquest Pro 12, the Confianza 20, and so on. This method is most suitable for short, straight CTOs, because otherwise the risk of penetration is significant. And the third strategy is the sliding strategy, in which we usually use hydrophilic guide wires with the polymer covers, such as Fielder series or Pilot series from Abbott or Whisper from Abbott, and so on. They have to be lubricious wires that go into the channels, and they slide into the microchannel. And there are some special guide wires like the RG3 for retrograde approaches of the CTOs, or the not so new wire, the SWAP3, which is very good for septal navigation, surfing, and also for successfully going into the true lumen in spontaneous and iatrogenic dissections. And also the rota wires, which are used for delivering the RotaPro system. Now I would like to know if any of you have a preferred algorithm for wire selection in CTO, for example, which are the toughest lesions. I don't know who else has joined the chat. Dr. Marco. Can you
Hey
hear?
Leo,
Hi.
yeah. You say if we have a personal algorithm for CTO lesion in general, no?
Yeah.
As algorithm, I don't do CTO at the moment, so but at the end, I think the algorithm is from meaning do you have your personal algorithm for this
Lesion.
Mm,
Usually there are some operators who escalate the wires, for example, the Gaia wire. They escalate
mhm,
from Gaia 1 to Gaia 2 to Gaia 3 or Gaia next, and so on. My personal algorithm is I usually try to use an ultimate bros, for example, or Fielder XTA. And if
mhm.
I go, I usually escalate 2 or 3 wires directly. I don't go to a Gaia
Ah,
1 or Gaia 2. I directly go with a Gaia 3, for example, or Gaia next 2, Gaia next 3.
for example, for the two CTO that I did, I did in this way, meaning Gaia 1, Gaia 2, Gaia 3 during my fellowship.
Yeah. I know many
As
operators escalate from wire to wire, but I
yeah,
usually
exactly.
escalate 2 or 3 steps.
So you don't do every wire, every step. You try
No,
to escalate. Okay, but
exactly.
what is the reason, Leo, if I can ask?
From my experience, if Gaia first doesn't go, probably Gaia second won't go as well. So I
Ah,
prefer
okay,
Gaia one
okay.
directly to Gaia 3. That's why I wanted to see if any of you have a different approach or different algorithm.
It's clear.
Okay,
Thank you, Leo.
welcome. Regarding guide catheter selection, the things here are more simple because there are not so many guide catheters that we can use. There are some basic catheters that we use for most of the lesions. The most commonly used guide catheters are the Judkins, Amplatz, and extra backup support. The EBU from Medtronic and XB from Cordis. I've never used the VODA or Q-curve. I don't know the catheters. Maybe in other countries you have it. We don't have them. Other catheters include the MPE catheter, the multipurpose, or the internal mammary artery catheter. The Judkins catheters have two curves, the distal curve and the proximal curve. The distance between the two curves is the number that we see on the catheters, for example, 4, 3.5, 3, and so on. For the femoral approach, the standard distance between the two curves is 4 centimeters. Using these curves from a femoral approach, we will have the catheter introduced in the left main with very few motion. From the radial approach, the 3.5 is best suited for most of the left mains to be cannulated. Regarding Amplas catheter, they provide strong passive support for the advancement of wires and devices by resting against the back wall and aortic cusp. The Amplat's left catheter is useful for downgoing the circumflex and the right coronary artery, while the Amplat's right is useful for engaging horizontal or superior takeoff of a saphenous venous graft and also for right coronary. The problem with Amplas catheter is that we always have to work with them under fluoroscopic guidance because they are a bit more aggressive and they tend to engage deeply into the coronary ostia. Also, when we disengage the catheter from the right coronary artery, for example, sometimes when we just pull the catheter, it has a tendency to go deeper into the artery, and sometimes it can cause severe damage to the arterial wall or dissection, important dissection. So we always have to be very careful with the Amplat's left in the right coronary. The extra backup catheters provide both active and passive supports. They are more commonly used for left coronary arteries interventions. They can be used for right coronary arteries, but they are less predictable and they can go very deep into the coronary, so I wouldn't recommend it. Some other special catheters are the multi-purpose guide catheter, which are most useful for the downward pointing bypass graft to the right coronary, and they are also used to cannulate the high left main coronary artery takeoff or inferior pointing native right artery. Also, the internal mammary artery catheter is suitable for left internal mammary artery PCIs, and the curve facilitates the engagement of this artery without damaging it. Here we have some tips and tricks for different complications that can appear during catheter manipulation. For example, to prevent air embolization that can appear during catheter manipulation, we have to always aspirate adequately following guide wire removal or anything we remove from the catheter. And also consider using pressurized saline black flush with the Y adapter when introducing bigger size devices. When we have arterial pressure damping, we can consider possible causes and address them appropriately, like ocil stenosis, coronary spasm, and so on. How we can deal with this? We can use smaller size catheter, trying to always be coaxial with the vessel, use side holes catheters, and so on. Also, we have to be very careful when manipulating catheters when we need bigger support, because sometimes when we use the deep intubation, we can cause more damage. So we always have to consider this. Also, the same question: what are your favorite catheters for left coronary, and do you prefer to use bigger size like 7 French, or do you use smaller catheters but with bigger curves?
Thank you, Leo.
Thank you.
Thank you.
If you
No, I
have any
think
questions,
no, thank you for the lesson. It was so clear, and for my personal algorithm in general, I use standard catheter. From a diagnostic point of view, always JL 3.5 and and JR 4. I I have to say that as what I learned is to use the XB catheter upfront catheter for a PCI, for example.
Exactly. It's the most common use.
You said that you do use as AXB catheter as first catheter in a PCI.
I personally use the EBU, not the XB.
The EBU, okay, you use the EBU, okay.
This is my standard.
Okay.
And when I have calcific lesions that I think and I expect to have difficulties, I usually go for a femoral approach with at least 7 French. This is my standard.
I
approach.
do the same. I do the same. Mainly for treating left main or things like this. Always 7 French femoral. Sometimes we use the slender with a 7/6 radial.
Okay. And
Sometimes.
also regarding standard approach and personal algorithm, when I have very calcific lesions,
Mm-hmm.
usually go with a body wire because in case of perforation, I can do a ping pong technique without using 2 catheters. For those who went to Rome and saw the live case that Gabriele Gasparini had, and he had a very bad perforation. He used this technique. He had 2 wires in the vessel, and he inflated the ball on 1 wire and went with the papyrus stand on the other one and change very fast. So that is my standard approach.
So in this case you use 2 guide wires, 2 body wires, okay? 2 body wires. In this case, one is a workhorse wire. The second one is an extra support as strategy.
Exactly.
Okay.
Exactly.
And then if you have a perforation, for example, with the first one you inflate the balloon, with the second one you can prepare
Always stand on the
the
second
cover
one
stand.
very fast. Yeah.
Oh,
Yeah.
yeah. Oh, this is a really nice. This is really nice because you are able to move faster in case of a complication. Yes.
Exactly.